Okay, let's get started. Already got the access to all the rest of the videos. I'll be posting them, sending them to you by email, and I'll also be posting them in the Google Classroom. So, and I'm gonna go ahead and put the rest of the assignments on there too. And whenever you guys are ready to finish up test number 2, let me know. I got access to it too. Okay, so we're gonna be dealing with one chapter today, which is chapter 40. Patients with special challenges. And then the next one, I don't know if I'm going to have time to cover it. It's the combat veteran also. I don't remember how long that one is, but this is a pretty long chapter. Patients with special needs or challenges. Yeah, basically some patients have special health challenges ranging from obesity to homelessness to dependence on medical technology like respirators, um, and whatsoever. So medical technology ranges from hearing aids to mechanical ventilators. Advances in medical technology allow people with certain medical problems to basically live at home. Now, the key thing is that you need to know how to operate some of these devices. If not, find somebody in the house that knows how to operate these devices. Okay, any number of medical traumatic conditions can actually cause a loss of function to a body system itself also, as in, getting into an accident and becoming a hemiplegic, quadriplegic, or whatsoever. Impairment can also result in aging, birth defects, chronic illnesses, traumas, abuse, neglect, and other causes. Like I know that one of the ones that uh, is out there nowadays is also human trafficking. So, the sensory impairments. Remember, we have 5 senses, and they can all be messed up with. So, sensory impairment includes problems with hearing, vision, and speech. Sensory deficits can also lead to difficulty communicating. And there are steps that can improve communications with patients who have sensory deficits. Hearing impairments, you have deafness, is the inability to hear. Yeah, deafness can also involve one or both ears. A patient may actually be partially or totally deaf. And with these patients, whenever you're dealing with them, make sure that they have their devices on, and that they have, that they have them on themselves, and that they have them on, turned on. Okay. Vision impairment may be caused by disease, injury, or degenerative disorders. Problems include glaucoma, diabetic retinopathy, and cataracts. Vision loss can actually be acute or gradual. Now, it happens all of a sudden, or it takes its sweet time to actually happen. Speech impairments, articulation disorders are caused by impairments in the tongue or other muscles. The patient cannot pronounce words correctly and can actually result from learning words incorrectly or from a hearing impairment. Voice production disorders can also occur from damage to the larynx or vocal cords. And we get to see these with patients that have had surgery on their larynx, especially like the ones that had cancer. They have this little vibrating device that they actually helps them talk. The sound produced may actually be harsh, hoarse, or unusual pitch, or have nasal distortion. Accommodations for patients with sensory impairments. Hearing impairment, make sure hearing aids are available and turned on. Make sure that the patient can see your face. So a lot of these patients that have hearing impairment can actually read lips, communicate with in writing, or use sign language interpreter if available. Vision impairments, usually you have to speak clearly, explain what you're going to be doing before you do it, transport service animals if possible. I know a lot of the ambulance companies here still have not up to par with transporting the service animals. Uh, if necessary, allow the patient to place their hand on your arm and shoulder so you can guide them through uh, to the ambulance or wherever you're taking them. For visually impaired patients, speak clearly and always explain what you're going to be doing to, like taking a blood pressure, taking their pulse, whatsoever. Sensory impairments, accommodations for patients with sensory impairments, like we have speech impairments, ask questions that allow the patient to answer in as few words as possible. Do not finish the patient's words or statements for them. A speech impairment does not reflect cognitive ability. So sometimes you assume that there might be something wrong with their mental status just because they can't communicate correctly. So that could be farthest from the truth. Mental or emotional impairments. A patient with psychosis struggles with interpreting reality and might not communicate effectively with you. A patient with an extreme emotional dysfunction, such as depression or anxiety, might not be able to focus on your questions or respond appropriately. Developmental disabilities. They usually interfere with how the body part or system operates, can involve the brain, spinal cord, nervous system, or endocrine system, and can actually cause speech impediments, behavioral disorders, language difficulties, and movement disorders like tardive dyskinesia, whatsoever. Okay. A person with Down syndrome may have numerous disabilities, but can participate in normal activities with help from family members, family and friends. Autism. Um, to better understand the, the autism patient, keep in mind the following. Autism is identified by patient behavior. Patients might not communicate with you. Patients may actually develop a seizure disorder. They may have a difficult time reading facial expressions, and patients may actually have altered sensations, like heightened sensations, and they are prone to positional asphyxia also. Well, they can actually stop breathing depending on the position that you put them on. Autism Spectrum Disorders Foundation makes recommendations concerning the provisions for emergency care. Accommodations with patients with mental, more emotional development impairments include treat the patient with respect, rely on caregivers for information if needed, compare the patient's behavior to what is normal for him, and provide clear explanations. Accommodations for patients with mental or emotional or developmental impairments include patients are sensitive to tone of voice or body language. Also establish trust and avoid loud noises or extreme lighting changes. I'm sorry. Patients with brain injuries. Brain injuries can result in permanent damage. There may be changes in cognition, learning ability, emotions, and motor function. Causes can include infant abuse, meningitis, encephalitis, and traumatic head injury. A cerebral palsy, this is a motor impairment arise early in the development. The degree of impairment varies depending on the patient, and there's a difficulty controlling muscles, and there may actually be stiffness or contractures. In other words, where they bend their arms and they cannot stretch them out. Facial grimacing may actually occur. In some cases, there is cognitive impairment, and there may actually be communication difficulties. Uh, Disability from traumatic brain injury varies. So Disabilities ranges from mild speech impairments to being unresponsive or and ventilator dependent. Accommodations for patients with brain injuries distinguish between the baseline condition and acute changes. So in other words, it's hard to deal with a patient when it's the first time you see them, and what you see is what you get. The only problem is that that might be their normal baseline condition. So you need to find out if they're normally like this or they're actually had some changes. And the best person to actually answer this is the family members that are there. Being aware or of and manage any technology like pumps, ventilators, and catheters, which the patient actually relies on. EMTs for paralysis, the EMTs respond to patients who have been paralyzed from past trauma or stroke. Paralyzed patients are prone to a number of problems related to technology dependence, pressure source, and infection. Patients with paralysis or muscle weakness may actually want you uh, to arrange for transport of their actually assisting devices like a wheelchair or canes or a walker or whatsoever. Accommodations for paralyzed patients. A paraplegic displays paralysis from the waist down, following protocols regarding transportation of wheelchairs. And for ventilator dependent patients, keep the ventilator settings as you found them. Okay, you may need to suction the breathing tube or stoma that the patient might actually have. Remember, stoma is the tube that goes straight into the trachea itself. Be alert for possibility of urinary catheter. Keep the catheter back below the level of insertion. Make sure that feeding tubes and colostomy bags, not colostomy, colostomy bags are actually secured. The family is usually knowledgeable about how to actually best move the patient with this these devices. Now, obesity. Bariatrics is a branch of medicine that actually deals with the management of obese patients. If you want to deal with some of these, you want to, not that I'm trying to put product placement, but there's a show that comes out called my 600-pound life. And you get to see how, what these people are actually going through and how they're actually being transported or whatsoever. A person who is 20% or more over their ideal weight is obese. Okay, so you need to know you know, the body I'm sorry, well, you need to know, what the percent, how to calculate the percentage. A person who is more than 50% to 100% over their ideal weight, or more than 100 pounds over the ideal weight, is morbidly obese. In other words, they have the chances of actually dying. So the effects of excess weight on the body system in the cardiovascular system: hypertension, coronary artery disease, congestive heart failure, and stroke. In the respiratory system, you have obstructive sleep apnea, asthma, chronic obstructive pulmonary disease. In the endocrine system or reproductive system, you have diabetes mellitus, infertility, birth defects, and menstrual disorders. In the gastrointestinal system, you have esophageal reflux, liver disease, and whatsoever. In the musculoskeletal system, you have osteoarthritis, gout, back injuries, and immobility. And in the psychological, you have depression and suicide. Assessment of care: these obese patients follow a normal format, but modifications may actually be required because the patient's size. Now, I know there's special type of stretchers. They can actually take up to 500, 600 pounds. There's pneumatic stretchers also, or rolling cots, and there's special ambulances that deal with carrying the Patient that is morbidly obese. Accommodations for obese patients. Obese patients can actually have difficulty breathing um, in a supine position. If the patient is unable to protect their own airway, position the head in a neutral position. You may need to actually be, you may need to place folded towels or bath blankets beneath the shoulders and the neck itself, so you can actually raise them up just a little bit. When the airway is insured, turn on your attention to the oxygenation and ventilation of patients. Patients pay particular attention to adequacy of respiratory rate and tidal volume. And positive pressure ventilation of obese patients is more difficult because the amount of, I hate to say this, the amount of meat that they have around their throat. Um, lining, lifting and moving obese patients requires the assistance of an adequate number of providers. I know that there was a case years ago on this, this was from in La Jolla. I don't know if you ever saw it. And actually, I just saw the documentary that they had on it. Apparently, this morbidly obese woman uh, had rolled over her nephew and killed him. But then they found out that the injuries that the kid had were not conclusive of somebody just rolling over him. He had, major damage. So the obese girl, was actually covering up for the sister, who actually killed the son. So lifting and moving, and what they did is they showed when after the fact that they found that she was not guilty. Um, that 600 pound show actually sponsored her, her weight loss, and they actually transported her to Houston to get this operation. Now, of course, getting her out of the house, they had to break one of the back walls of the house. Then you had to have, and you had, I believe, I remember it was like 10, maybe 10 firefighters helping load up the patient, and they transported the patient all the way like that without a stretcher or anything because they didn't have any bariatric stretchers on here. Obese patients may actually exceed the structural limitation of standard ambulance cots and may require the use of a bariatric device. And the bariatric device, all it is just a stretcher that's wider and can handle more weight. And you get to see here one of these stretchers um, being loaded up into an ambulance with the assistance of a ramp. So bariatric devices include special cots designed to actually support the greater weight of the obese patient, and loading devices such as ramps and winches that actually interface with specially designed ambulance cot locking systems. Now, homelessness and poverty. We do have a homeless problem, even here in McAllen. And factors that actually contribute to homelessness include poverty, substance abuse, lack of affordable housing, mental illness, returning to society after being in prison, domestic violence, mortgage foreclosures, forced evictions, and natural disasters. Issues associated with homelessness: increased risk of violence and abuse, increased risk of illness and disease, discrimination from others, and reduced access to healthcare. The issues associated with homelessness: risk of violence and abuse, risk of illness and disease, reduced access to healthcare, limited or no access to education, limited access to modern communications, and not seen as suitable for employment in a lot of places. They need to have a home address. And if you're living from your car, you don't have a permanent address. EMS is often summoned uh, to the street corners and other public places for care of the homeless patient. I know I've seen them under the uh, overpasses and the bridges that we have. I've seen some of actually setting up tent there. Okay. Places where homelessness may actually find refuge include abandoned buildings, public places like parks, trains, bus stations, airports or college campuses, vehicles, um, improvised shacks or sleeping bags, unoccupied houses, and homeless shelters. Um, Patients with in poverty may actually face many of the same issues as the homeless, including accidental trauma, physical abuse, crime, chronic medical conditions, and limited access to health care and medications. People who fall below the poverty level are at greater risk of illness and injury because of the environment in which they actually live and the lack of resources which uh, to seek primary medical care. Accommodations for patients who are homeless or poor do not be judgmental and display respect. Be an advocate, realize a patient may actually need your help, and become familiar with the resources in your community to help them out. Now, abuse. Abuse is any condition or failure to act that results in unreasonable suffering, harm, or misery to a person, whether it's physical or mental. Abuse transcends all ages, gender, race, and social economic groups. Children, elders, and domestic intimate partners are some of those who may actually be abused. You might be the only hope for the victim when it comes to human trafficking and have only one opportunity to save the individual from human traffickers. The victim of human trafficking, common characteristics of victims of human trafficking can actually be men or women, adults, and or children. Usually characteristics of victims of human trafficking, runaways and homeless youth, victims of domestic abuse, victims of sexual assault, victims of social discrimination, and victims of war or conflict. Common characteristics of victims of human trafficking, common settings, prostitution rings and escort services, pornography industries, stripping or exotic dance clubs, massage parlors, agricultural farms or ranches, factories or sweatshops, hotels, nail salons, and home cleanings. Common characteristics, victims' characteristics, control physically or psychosocially or psychologically by someone in this at scene. Doesn't have the ability to actually leave. All information is provided by someone else. There's no ID and few or no personal possessions. Psychosocial, psychological, and behavioral clues to help identify a victim of human trafficking. They exhibit a feeling of helplessness and shame, guilt, or self-blame or humiliation. Has the and eating or sleep disorders, is addicted to drugs or alcohol, appears to be emotionally numb, and shows evidence of trauma, bonding with the trafficker itself or himself. Physical clues, signs of physical abuse, chronic back, visual, or hearing problems, skin or respiratory conditions, disease such as tuberculosis and hepatitis, uh, clearly visible tattoos, and inappropriate clothing for the weather itself. Management of a suspected victim of human trafficking. Ensure the scene is safe, provide emergency care for any illness or injury according to your protocol. If you cannot transport the victim, contact local law enforcement. Victims of domestic violence, women who are the highest risk of being subjected to domestic violence are separated or divorced. Minorities, disabled, pregnant, and cohabitation with a same-sex partner. The abuser typically isolates the victim. Okay. Types of domestic abuse: the use of physical abuse, the use of derogatory terms, threat of degrading behavior, sexual activity with the victim without consent. Victims not permitted to practice religion and financial or material control. Uh, Cycles of violence, you have different phases. In phase one, the tension between the victim and the abuser increases. In phase two, the violence occurs regularly, increased by frequency and severity. Phase three refers to as the honeymoon phase, in which the abuser apologizes and sometimes buying the victim gifts. Assessment findings of domestic abuse. You can find physical, emotional, psychological, psychiatric, or sexual. Approach the scene and victim of domestic violence. Ensure that the scene is safe before entering. Do not confront the abuser or the victim. Do not get in between the abuser and the victim. Do not allow the abuser or victim to get between you and the door. Remember, our first priority is to find the way out. Okay. Approaching the scene and victim of domestic abuse. When away from the abuser, ask the victim about the abuse. An example is this kind of question. Uh, this could be violence against women has become a health issue. I ask all my female patients if they have any experienced any type of abuse. Have you been abused as a child or an adult? You know, something non-judgmental and non-leading. Okay. Presenting evidence and documentation. Do not destroy any possible evidence. On your PCR, perform the following: include location and description of the injuries, report the mechanism of injury, note any injury patterns, and objectively note any comments made by the victim. Like the victim states this or the victim states that. Okay, many patients who have required hospital care can actually now be cared for at home when it comes to technology dependence on some of these patients. And this is part due to medical technology. Technology may actually be life enhancing or life sustaining. In other words, they can help them with their lives, or they can actually just keep them alive. Reasons for EMS be summoned include failed equipment. In other words, the respirator went wrong, or they're showing something that the mechanical aspects of the machine is not doing. Change in the patient's clinical condition, and patient experiencing some other emergency. EMTs must have a basic understanding of the technology the patient is actually using. You will often have to rely on the patient and the caregivers for specific information about the equipment. Patient's primary care provider can actually usually provide information about the equipment on which the patient relies on. So somebody, they have what they call a provider, or like some friends of mine that work in this system, a provider. They can actually tell you how to use a device, and if there's something wrong with the device that they can't actually manage. Questions about the technology include: where can I get the device information? What does the device do? Can I replicate the function if it fails? Let's say it's a respirator. Can they use a BBM? Duh. Will the device have an effect on the assessment of the findings? Has this problem ever occurred before? How did you fix it? Has someone tried to remedy the issue itself? Focus on the task. Keep the airway open. Establish and maintain an adequate ventilation. Maintain adequate oxygenation and support circulation as needed. Medical oxygen. This is one of the deals that we deal with, especially when it comes to COPD patients and emphysema patients. Home oxygen equipment is similar to what you are actually used to. Oxygen may actually be supplied from a cylinder, an oxygen concentrator, or a liquid oxygen system. Now, the cylinder is what we normally carry. The oxygen concentrator, it's a little box that what it does, it actually filters out everything and just keeps the oxygen and transports it into the patient. And it's used with nasal cannula whatsoever. I've seen a lot of patients that have these oxygen concentrators. Common technological problems with oxygen systems. The oxygen is not flowing freely. Uh, they might actually have faulty tubing, or check to see if for obstruction of the place of the tubing itself. Dirty plugged humidifiers. Remove the oxygen supply, clean and refill with sterile water, and replace the pre-filled oxygen. Buzzer goes off on oxygen concentrator. Unit may be unplugged, it's losing charge. Check the plug itself. You might actually have power failure. Check fuses, circuit breakers, and in case of power outages, and backup oxygen tanks until the power is restored. Or call EMS as necessary to make use of the oxygen administration from the ambulance or the hospital itself. Oxygen tank empties too quickly and or hisses, you might actually have a leak when it comes to the oxygen tank. The O-ring might not be there, or the O-ring might actually be cracked. Between the O-ring and the called the regulator. Open the window, extinguish any flames, and actually summon help from the fire department, EMS, and other suppliers. Apnea monitors. They're designed to constantly monitor the patient's breathing and emit a warning signal should the breathing stop. Okay, may also monitor heart rate and used for some babies, especially premature newborns. Determine how long the monitor has been emitting an alert. Determine whether the caregivers have performed any interventions. And if the patient is breathing normally, provide oxygen to the infant and transport them to the hospital for evaluation. Pulse oximetry. It may be used in home by patients with apnea monitors and respiratory problems. Treat the patients the for the presenting problem. Apply the pulse oximeter from the ambulance and ascertain what interventions, if any, were done. Tracheostomy tubes. Tracheostomy is a surgical opening into the trachea itself to provide an alternative route for airflow by passing the nose and the mouth. A tracheostomy may be temporary or permanent. A permanent opening is considered to be what's called a stoma. And I'll show you a picture of some of them. A tracheostomy tube is placed into the tracheostomy to keep the patient to keep it patent, it's open. The tube may actually be single or double lumen. Patient with a tracheostomy may or may not have or be able to actually speak. And a patient emergency includes tube obstruction by mucus or dislodged inner cannula that might have fallen out of place. Basically, this is the tube itself, the tube that goes inside the stoma. Okay, and most of these have an inflatable bag at the bottom so it doesn't get displaced. Okay, to suction the tracheostomy tube, measure the depth of insertion of the suction catheter by comparing the tracheostomy tube obturator. Okay, apply suction, slowly withdraw the catheter while the twisting, or if you're gonna be twisting it like this, I don't know if you can see that with the fingers, between your fingers, and rinse the suction catheter with still water between attempts. That way, there's mucus that's actually gotten trapped in there. You don't keep it clogged. And this is the way you hold it, and you put it in so you can actually suction on the way out. CPAP and BiPAPs, the continuous positive airway pressure, bi-level positive pressure, airway pressure, both provide therapeutic back pressure during during respirations. Some CPAP and BiPAP machines also allow the administration of oxygen during the use. Keep bronchioles, the CPAP and BiPAP usually keep the bronchioles open during exhalation, which provides oxygenation and ventilation and decrease the work of breathing. It is commonly used by patients with COPD or sleep apnea. Patients may actually depend on the ventilator, which when it comes to mechanical ventilators, because of nervous system disorders, neuromuscular disease, or other problems. Home units vary in size. It may actually vary significantly or cost and sophistication. Setting include the rate, tidal volume, and in some cases, the amount of oxygen provided. The tubing called the ventilator circuit attaches to the patient's tracheostomy tube so they can actually be ventilated. A high pressure alarm is activated when the presence or the pressure needed for lung inflation exceeds the present volume. In other words, it needs more pressure, so it's already sensing that there's an obstruction. These causes include secretions, including the tracheostomy tube, kinked ventilator circuit, in other words, a tubing, and tracheostomy tube movement. Um, a low pressure alarm is activated when the tidal volume falls from 500 to 100 mLs below the set volume. This indicates a problem with breathing circuit, such as a disconnected segment or a leak in the tracheostomy tube cuff, which remember I told you that all these have a little cuff that you inflate. Most of them, not all of them. Apnea alert. Some patients on the ventilator may have some respiratory effort, and the ventilator is set to trigger when the patient takes a breath. The apnea alarm triggers when the patient stops breathing. The low FiO2 alarm occurs when the oxygen is actually disconnected or depleted. Ventilator alarms can actually represent a change in the patient's clinical condition or problem with the ventilator. Troubleshoot the patient and the ventilator itself. Because the device is used to support or replace a lost function, you must assess its adequacy in doing so. You also will perform your usual primary assessment, history, and physical exam in an unusual order. In the usual order, sorry. And we're bringing in circulation, remember that. Accommodations for patients with airway respiratory devices. You may need to suction the tracheostomy tube. For patients with ventilators, troubleshoot both the device and the patient itself. Make sure that there's no leaks. Okay, if the ventilator provides adequate ventilation, allow it to do its job. If the ventilator does not provide adequate ventilations, you will need to use a BVM to actually do it. Ensure you have adequate help to move the patient and ventilator itself. And this is what the tracheostomy tube looks like and the connector. Uh, all connectors uh, fit uh, will fit together because it's a 15 to 22 millimeter adapter, everything in respiratory. Patients may have a vascular access device, also known as VAD, for chemotherapy, dialysis, total parenteral or nutrition, or antibiotic therapy. VADs may actually be placed in a variety of locations. The device may have an external catheter portion or may actually have a port implanted under the skin, like what they use in dialysis patients. You have the central intravenous catheter. It's a long, thin tube catheter inserted into the vein of the arm, neck, or subclavian vein just below the clavicle itself. You have central venous lines, ports secured in the anterior chest, just below the clavicle. You have implanted ports, which are surgically placed beneath the skin. Vascular access, um, you can actually call it what they put a PIC line on there, and they might you're gonna probably get to see the let's see if it's right here on the arm. You're gonna get to see it. Try not to take the blood pressure in that arm, only because you might actually damage something in there. Accommodations, obstruction of blood clot may actually occur. Patients may actually take anticoagulants. Air embolisms may occur. Note any bleeding or signs of infection. The EMT does not assess ventricular access uh, devices for medication administration. If the patient is actively seizing or feels as if they are about to have a seizure because of the aura or special magnet can actually be passed over the device to trigger it to actually deliver the burst of electrical activity. And this is what we call a vagus nerve stimulator. Renal failure and dialysis. You have acute renal failure occurs when there is rapid loss of renal function. Acute renal failure is often reversible. Chronic renal failure occurs when there is a progressive loss of kidney function over a period of months to years. Dialysis removes the backup toxins in the kidney can no longer filter. If you take patients to dialysis, this is what's happening. Hemodialysis, blood is actually extracted from the body and sent through a machine called a dialyzer. The procedure is performed in the dialysis center, and it requires a dialysis shunt to remove blood from the body and return it back in there. Fluid is now, you have the peritoneal dialysis, which is fluid is placed in the peritoneal cavity through a port in which it acts to remove waste, and then it is actually emptied from the peritoneal cavity. Dialysis can actually be performed at home, but is less effective. If the patient is receiving dialysis at a facility and it can actually be set at the dialysis machine, do not attempt to actually remove the patient prematurely. Only dialysis center staff should remove the patient from the machine itself. Patients with peritoneal dialysis may actually develop peritonitis or inflammation at the insertion site of the catheter and may actually be dislodged. Feeding tubes. Feeding tubes are used to provide nutrition to patients who cannot chew, or swallow. Patients' tubes include nasogastric tubes or oral gastric tubes, gastric tubes, or jejunal tubes. For long-term nutritional support, a feeding tube may actually be surgically inserted into the abdominal cavity, directly into the gastrointestinal wall, so this is what you get to see. Ostomy bags, surgical opening through the abdominal wall to actually which a section of bowel is diverted so that the fecal material is directed outside the body into a bag itself. There are different sites where you can actually place the ostomy bags. Urinary tract devices. Okay, the urinary catheter is used to empty the bladder when there is urinary tract dysfunction. Urinary tract devices types, you have the Texas, which is an external catheter, the Foley, which is indwelling through the urethra itself, and the suprapubic, which is surgically inserted through the abdominal wall, straight into the bladder. An external urinary catheter also exists, where you can actually put it on there so they can, urinate uh, while they're urinating and getting rid of a lot of the urine itself. Now these devices, this is the internal urinary catheter with a balloon. Is actually inserted through the urethra, straight into the bladder, and there's a cuff that's actually inflated. I did get to see one in an ER where a guy just pulls it out without deflating the cup itself, which must have been very painful or gratifying depending on the patient. Uh, Accommodations for patients with gastrointestinal and genitourinary devices. Problems include obstruction, infection, and displacement. If the device is displaced or dislodged, do not attempt to replace it. Drain the catheter bag prior to transport and document the appearance and how much urine was in there. Keep the catheter bag lower than that of the side of the insertion itself, so that way it can go down by gravity. Interventricular shunts. Uh, these are and this is not interventricular like in the ventricles of the heart. This is usually in the brain. Hydrocephalus occurs in the excess cerebrospinal fluid as it accumulates, which can actually cause increase in intracranial pressure. An interventricular shunt allows the excess fluid to actually drain out. And I've seen this on kids, and they basically put a shunt so they can actually drain fluid that's actually excessively uh, forming in there or getting trapped in there. Complications include infection, shunt occlusion, and subdural bleeding. Infection may present with malaise, fever, and headache. Okay. Shunt obstruction causes the following signs of increased intracranial pressure: headache, seizures, vomiting, altered mental status, sensory or motor dysfunction, respiratory depression, pupil changes, and increased blood pressure. Initial complaints include confusion, difficulty with simple tasks, and headaches. Manage the airway, and if breathing is inadequate, provide positive pressure ventilation with oxygen. The life expectancy of terminally ill patients, the life expectancy of terminally ill patients is generally 6 months or less. Patients may receive palliative care, and hospice is a physiology of care aimed at palliation of symptoms for patients with and support for their families themselves. Patients receiving hospice care often are ill with the following: cancer, AIDS, Alzheimer's disease, uh, cystic fibrosis, congestive heart failure, and COPD. Okay, provide emotional support. If there is confusion, determine the patient and family's intent. Uh, a desire to not be resuscitated does not mean the patient does not want comfortable care. Okay, and that should be it for this chapter. Any questions? Okay, so on Wednesday, I'll go ahead and provide you with the rest of the test. And then I'll start putting the assignments back up in your email and also in Google Classroom.
Alrighty.
So I'll see.
Sir,
Yeah,
I have a personal question.
yeah.
Because me and my supervisor don't know what to do because I recently I had the chicken pox last week.
Okay.
And I have no new blisters or anything on my blisters that I do have. They're scabbed over. You think I'm ready to go back to work?
Oh, well, I don't remember what the time period is for chickenpox. How did you get chickenpox?
I genuinely don't know. I don't know if one of our patients had freaking what's it called? If I got it from
Chickenpox?
one of our older patients that might have had
But you were
what's it
diagnosed
called?
with chickenpox, right?
Yes.
Okay, not what do you call it? Shingles.
No, not shingles, but the doctor says I could have gotten it from shingles if one of our older patients have
Yeah,
shingles.
yeah, because in a lot of situations it could be either one. So, um, I don't know. Did you get it? Did you get any medication?
I just got an antiviral and a steroid for itching. But
And
I mean,
are you done with the medication?
yes.
Okay, you would need to. I would
I
call
mean, the
Cindy.
the doctor's excuse was only for a week, so
Oh,
I
okay.
think I should be good to go.
Do you still have blisters forming,
No,
or
I
are
don't have blisters
they
forming.
dry up?
Yeah, they're all dried up. I mean, I don't even have very much scabbing.
Okay.
It's very minimal too.
Okay. Well, I would talk to Cindy to see
Hmm.
if the medical director clears you
To work.
because it's a company issue, and I can't interfere with the company. You know what they decide to do.
Alrighty.
Okay.
Well,
Well, I hope you feel
anyways,
better.
thank you.
Okay. Bye.